The majority of patients will end up coming off multiple medications. It's not unusual for people to come off 3, 4, 5 medications after, a couple months with us. It's pretty unusual that we add a medication.
Wellness isn't black and white, so why should your choices be? On High Energy Life, we dig into nutrition, health, and science with an open mind, inspiring you to make choices that actually work for you. Our mantra: embrace nuance, ask questions, and always reserve the right to change your mind. Now enjoy today's episode. I'm your host, Carly.
And I'm your host, Alex. You're, obviously known as the carnivore doctor. You're one of the biggest names in the carnivore space. So I'm curious, what age did you start when you switched over to carnivore, and roughly how long ago was that?
Yeah, so I was 49 when I did it, and I'm 59 now, so 10 years. So basically,
right.
pretty
Well,
easy.
there we go.
Yeah.
So I'm curious, what were you doing beforehand, and what prompted you to try out carnivore?
Sure. Yeah. So, so as I mentioned, I was 49 at the time. I was probably about 6 or 7 years into my sort of journey into nutrition. As you will, I've always been an athlete my whole life. And despite that, I was probably in my, kind of early 40s and just feeling old, man. I was just, feel like, I was kind of falling apart a little bit. Aches and pains, putting on weight, probably developed metabolic disease. And so I started out I just started out with, calorie cutting and eating low fat and fiber and, lots of fiber, lots of, lean protein. And I did lose weight. I managed to do that. Was exercising like a maniac. I was working out 3 times a day. I was a practicing surgeon. I was get up at 4 o'clock in the morning and jump a couple thousand jump ropes, go to work. On clinic days, I go to the gym and work out over my lunch hour. And then in the evening, I'd come home, see my kids, put them to bed, and then do another couple thousand jump ropes. And I did that. I went from like 280 down to 230 in 3 months. And I was a big 280. I wasn't like a fat 280. I was just a big, strong. I was, competitive power lifter, Highland Games world champion. I was, just a big guy. So yeah, I did that, but it just wasn't sustainable. There's no way I could continue doing that. I was, not eating enough and just exercising, over-exercising. So I had to find something that was more sort of manageable for me. I kind of slipped into a paleo diet for a while as that was popular. This is about 15, 16 years ago. And then kind of made my way into low carb and eventually on a ketogenic diet. So I was on a ketogenic diet, and this is the first time for me I had noticed that my appetite was like not big. Because I was a big guy, ate big, everything was big for me. And I just, for the first time in my life, I was like, I'm not hungry. It was just a bizarre experience for me. And I remember that on a ketogenic diet. So I pursued, I was continuing that. And then I ran into these people online doing this, what they called a zero carb diet, which was, basically an all meat diet. And it wasn't called carnivore at the time. And I thought these people were, they said they were just basically eating meat. And I thought, well, that's pretty weird. And it seems like kind of crazy. And I was like, well, what about scurvy? What about fiber? What about, vitamin deficiencies and all the stuff that people are concerned about? And these people seem to be doing quite well. And they had some interesting literature that that they were sharing, and some very, very compelling anecdotal stories on and transformations I was seeing. And, I at that time was like, you know what? I'm not really big on the low fat stuff. I kind of understand some of the low carb physiology. Let me give it a try, see what happens. And so again, this is 2016. I do it for a month, and I was just shocked, man. I was like, man, I feel great. I remember I had like I said, I was almost 50 at the time, and I had a little bit of knee pain that I developed over the years of, professional rugby, Highland Games, powerlifting, strongman. I put my body through hell as an athlete. And so I had some aches and pains, which I just, said, shit, I'm almost 50. It's normal. And that just went away. It was like within a month, I was like, man, my pain went away. This is weird. Because I'm an orthopedic surgeon, and I know a lot about joint pain and tendon pain, and trying everything I knew wasn't working. But this diet made it go away, and I was like, holy cow, that blew me away. So that
I want to
was
jump in right there, actually, before you continue. Handful of questions. So, you've been an athlete like myself. You've been an athlete for a lot longer than I have, but effectively both of us probably our whole lives. Myself more on the endurance side, but you were very much into strength and powerlifting. To my understanding is, you were basically world class, even well before you ventured into carnivore, right?
Yeah, I was like I said, I was more strength, explosive sport. Rugby is kind of a hybrid sport. You do a fair bit of running in that. I played professionally there. I was, I'd had several national American records in powerlifting in the various federations. I say a little bit of a grain of salt because powerlifting was so many fragmented with so many federations. It's like you could be the American record holder in this one and not have the same as some other guys. So it was kind of weird. But I'd set several records. I was a decent lifter. I was deadlifting close to 800 pounds, as a drug-free athlete, which I'm so proud of the fact I did that. But that was when I was like 33, so well before I was carnivore. So I put on a lot of muscle on a mixed diet for sure. It was always high protein.
Anybody that's lifting 800 pounds, that don't care how big you are, that is a lot of weight to put.
Yeah, I was weighing about 285, 290 when I did it, but still, it's I could still deadlift decently. I was just built for that. And then I went in there and I did strongman competitions, and I remember one Texas Strongest Man. I was in the 300-pound division, so it was like a divisional winner of one meet. Early on, this is early on when strongman was just starting to get kind of popular, where there's more competitions, and I went to the very first ever what was called NAS, National Association of Strength. What was it, Strongman or something? Anyway, I can't remember the name, but anyway, it was in Dallas, Texas, and I ended up taking like 5th at nationals. And I saw the writing on the wall that if I wanted to be good, I would most likely have to take drugs. And I was like, I ain't doing that shit. I just want to be on the drugs. I'm not interested in that stuff. So I stopped doing that, and then I got interested in, I think, Highland Games. Highland Games are these Scottish sport where you put on a kilt and you throw stuff. Basically, you're throwing these big poles, these cabers. You run and you flip them over, and you shot put stones, and you throw these hammers and weights and all that stuff. And I got into that. And was just, because I was naturally strong and athletic, I wasn't very technically good, but I was strong enough to where I was able to I ended up winning the world championship in that as a master's athlete over 40. Won that in Denver in 2010. And then, then I got into nutrition and stuff like that. Yeah, so I had a long foundation, and I've been lifting weights since I was 13. I've been lifting weights for 46 years. God. And I probably started getting interested in exercise when I was about 8, so about 50 years of exercise. So, I've been at this for a long, long, long time, and hopefully have many, many more years to go, because I still enjoy it. I still like doing it, and it's part of who I am.
Based on your athletic posts on X, it does appear that you're going to be going for quite a while.
Well, knock on wood, hopefully, barring injury, illness, disease, you never know how many years we all have, but I'm going to keep plugging away as long as I can.
Yeah, definitely. So before, 15, 16 years ago, before you switched over to keto, you said you were on a mixed diet. Now, would you have classified it as a relatively clean diet, or a lot of people, when they're a lot of strength athletes, when they're trying to put on weight, they call it a dirty bulk, where I'm just hitting my macros, I'm eating whatever's in sight, pizza, ice cream, whatever it is. So would you classify yours more as kind of just, I'm eating whatever as long as it fits in my macros?
I didn't eat a overly high amount of just pure junk. I would eat from time to time and have ice cream and pizza once in a while, but I was eating a lot of protein. It was chicken breast, and it was, some steak, and it was, lots and lots and lots of protein powders and, dairy products and stuff like that. So I ate a lot of protein. But I was eating, I was eating probably most days 8,000 calories a day. I was very active, both in my surgical career and my athletic career. And I'm 6'5", I'm 280 pounds. I just ate, always eating. So it wasn't any specific, like this. And I was never interested in bodybuilding, so I never got into dieting or any of that stuff. I had zero desire to do bodybuilding. And today I still haven't. And plus, I'm just not, I'm long-armed and legged, and I would never be a bodybuilder. I'd be a horrible bodybuilder, so never had a desire for that.
Okay, so overall, you were eating relatively clean, especially compared to the average American. A lot of protein.
I was eating like a strength athlete. You can just take that for what it is. I did have my share of like I'd sit down and eat. I remember I'd eat these Yoplait yogurts. Flavored like orange lemon are my favorite. I would eat 10 of those in one sitting. It was just mass. I'd eat boxes of cereal. I'd have like crackling oat bran. I'd just throw the whole box in a big old bowl, throw a half a gallon of milk in there, and go through that. So. I just ate a lot of food, man. It was just a ton of volume.
Mm-hmm. Okay. So then the switch to general keto, would you say that the way that the type of foods that you're eating overall was cleaner than compared to Yoplait yogurt and cereal?
Yeah, I mean, when I was on keto, yeah, I mean, it was a lot of meat. I was always meat heavy, and then I had my sort of token salad. I was eating giant spinach salads. I remember that. I don't even know who Mark Sisson was, but he was talking about these. Eat this big ass salad the size of your head, and so I get the biggest bowl I'd have. I'd throw a pound of spinach in there, and then I'd put in all the keto crap. I'd put in like eggs and bacon and balsamic vinegar and olive oil and some nuts and maybe a few berries in there. And I would eat a ton of that stuff. And that was my keto experience. And that was, like I said, that was not bad. I mean, I felt decent on that. I ended up, maintaining weight. I mean, like I said, I went from 280 down to 230-ish, kind of settled in at about 240. And I maintained that for about 10 years, on that approach, just keto and then early carnivore. I just kind of hung out at about 240.
Okay. And so the switch to keto then, did you feel, I mean, joints and all the reasons that you shifted towards keto, did you feel any improvements in the joint pain and such that instigated that change?
Not so much. I mean, I really noticed it on carnivore, quite honestly. I mean, the biggest thing I noticed on keto was my appetite was in check. That was the thing that probably had me the most excited about it because I was just not hungry. And the weight was fairly easy to keep off, but I mean, I still had a little bit of pain in my knee, and I had, just a few things, and I was, I've got to spend so many years now that I did that. I mean, I was never like real sick. I mean, I was never like somebody that had multiple diseases or anything like that, but I think that keto was definitely a step above anything I'd done prior to it, just for the reason of the appetite. But the actual, I felt for me, carnivore was, I mean, the two biggest things I noticed on carnivore was like all these aches and pains that I had as a nearly 50-year-old man, or I guess I started as I got into my 50s, that I had in my 40s had gone away, which was really nice because then I could train hard again. I was like, yeah, I can. I mean, I always train hard, but, sometimes I would have to like work around injuries or pain. It's just like, my knee hurts today. Maybe today's not going to be a leg day. Maybe today we're going to do whatever else, and I'd have to kind of constantly move my schedule around based on what I felt like. And the other thing was my digestion. On keto, I just, I mean, digestion was as it normally was for me. I mean, you'd kind of feel it a little bit, maybe your stomach rumbling a little bit of discomfort occasionally if you ate too much. And then when going to carnivore, it was like there's no appreciation of a digestion at all. It's like going from like an old beat up 1978 Honda Civic, with cracked windows, driving down the road and then going into a German luxury car. It was like no noise. It was like so calm, the digestion, that I didn't know what was going on. Those are the two biggest things that I had noticed personally. Those two things, joints and gut.
And that was specifically then from carnivore then.
Yeah, going from keto to carnivore.
Okay.
Yeah.
Okay. Yeah, that's really interesting because when I was keto for full keto for about 2 or 3 years, and for me it was specifically healing from lower back pain. I mean, I was a young 20s right out of college. I've always been an athlete, but then I get an engineering desk job and got some back pain and decided to try out keto for that. I've never been full carnivore. I am definitely animal heavy, but the keto for myself, that really cleared up my back pain. Now, of course, I'm not deadlifting 800 pounds, but that's really interesting to note that even the back pain and such, that keto wasn't able to clear up for you, the carnivore did. So that's really cool.
Yeah, and I've seen that, gosh, thousands of times. I mean, in fact, a high percentage of the people that go carnivore were already keto, particularly early on, and they just noticed. The reason they did is because they still had stuff going on, and it did seem to help for a lot of them. So I think that's a pretty, common experience. And, it gives you this, like, well, maybe that spinach salad wasn't helping me. I mean, it's just like, I know it's crazy. It's almost heretical to say that vegetables could be potentially bothersome for some people, but it is what it is. And for a lot of people, it does seem to be.
Mm-hmm. Yeah, I love the individual approach where it can be different for each individual person. One of the things that, I mean, you're known for, you post on your social media, is your athletic abilities, which are very, very impressive. it sounds like, I mean, you were already basically a world-class athlete before the keto and now carnivore.
Yeah.
Would you say that outside of...
Yeah, it's fair to say. I've never made the claim that carnivore made me a world-class athlete. I mean, I put in the work. I mean, I'm very proud of the fact I've busted my ass for almost 50 years. And what is happening now in my I'm almost 60 now, is that for the last decade, I have seen a dramatic improvement in things like joint health. And because of that, that has allowed me to train at these higher and higher intensities that I couldn't have done in my late 40s. I mean, if I would have continued where I was in my late 40s, I would not be where I am today, specifically. But I had a huge foundational base that I built up for years and years. And, the fact that, like, for instance, with the Concept 2 rowing, which I set, I don't know, 25, 30 world records on that thing now since I went carnivore. And in fact, I'll break a bunch more as soon as I turn 60. I'll break another 4 or 5 when I turn 60. So, I mean, this is because I believe I feel good and my joints don't hurt. But I still got to put in the training, and that is the biggest variable. The thing I would try to get out there to people is, yeah, diet is important, but training is probably more important when it comes to aging well. I mean, I think you got to train. Now, your diet should allow you to do that. If you're on a crappy diet that makes you tired and achy and sore and inflamed, then that's going to be a problem, And for some people, that means a higher carb diet does that for a lot of people. A lot of people I've experienced myself or talked with say, yeah, when they add carbs back in, their joint pain reoccurs, and it makes it difficult for them to do things.
Yeah, absolutely. I mean, it's both diet and nutrition and the training and maintaining the athleticism is both. It goes hand in hand. So it sounds like ultimately the switch to carnivore has allowed you to extend your life as a very high-end athlete.
I think that's a fair assessment of that, and that's what like I said, I know there's a lot of controversy around carbs and athletic performance, and I think certainly for certain activities like high intense, long prolonged activities like marathon running, then some level of carbohydrate makes sense. For other sports like very short intense things, I don't think they're necessary at all, quite honestly, because it's all mostly going to be creatine, phosphate system, ATP primarily, and carbohydrates are not really needed in a sense for that. And then particularly as you get older, and the considerations aren't just energy systems, but it's also, again, not having sore joints or inflamed tendons. And that's where I think the trade-off comes. So it might be that you can handle carbs, early in your career, and then as you get older and older, you got to find out what that minimum effective dose is. And for some people, it might be 0. Like me, I mean, I have had no problem, putting up world-class numbers. I mean, even, like I'll just use a rowing machine as an example. I mean, when I pull a 500-meter row in, minute 14, I'm literally, they're Olympic rowers I can beat with those numbers. I mean, literally as an almost 60-year-old man. It's not to say, they train for a slightly longer event. They're usually training for a 2K. So it's kind of like a 100-meter runner saying I can beat an 800-meter guy. I mean, there's not quite the exact psychology, but I'm 40 years older than these guys, so it's kind of like, there is some there's something going on there.
Yeah, definitely. So do you think then that carnivore for you, if let's say you had adopted carnivore 20 years before you did, do you think that alone would have allowed you to reach a higher peak than you did in your career? Or is it more about you've been able to maintain volume because your joints feel good, and so because of that you're not losing any ground, you're just not necessarily,
I think it depends on,
you're not above a peak that
it depends on what sport I did, and if I knew what I know now and how to implement it. Like I said, I think if you're going to do a carnivore diet and have minimal carbs in there, your training has to be dialed in to compensate for that. And I think you have to eat enough. And I think that's a really hard part. One of the reasons it's been so effective for so many people to lose weight is because it's so satiating. But the double-edged sword for that is for some people it's too satiating for them, and they can't keep the muscle mass because they can't eat enough. And so carbs facilitate eating more food. I mean, we know that carbohydrates, particularly high glycemic refined carbs, are incredibly not particularly satiating. You can overeat those far easier than just about any other macronutrient. And so without those in the diet, guys like, I remember Stan Efferding, the bodybuilder, was, had his vertical diet. He was feeding a lot of these strong men, World's Strongest Man, guys like Thor, and Brian Shaw and some of these guys. And he was just, they were eating massive amounts of protein, but he was also feeding them a lot of rice, and he put dextrose in the rice just so they could continue to consume the caloric needs that they needed. And so I think for, like a heavyweight lifter or somebody that's doing just massive amounts of high intense work, it would be challenging. But that's not all sports. Like for instance, to go out and run the 100-meter sprint or, row 500 meters, things that are taking you anywhere between 10 seconds and 2 or 3 minutes, I think you'd be fine on carnivore and very likely perform extremely well. But again, it's just, it's like, why do you do it? What would be the impetus to do it? And the reason most people do it is because they're sick, and they're, dealing with autoimmune disease or depression or diabetes or something like that. So, I think there has to be a reason to do it. For anybody and like I said, if I could, I always, laugh because people ask, well, what would you tell your 20-year-old self? And I'm going back and I'm saying my 20-year-old self would not be listening to some old guy. I'd have smiled and been polite and said, oh, whatever, dude. And just, even if I could turn back in time and say, hey, I'm you 40 years from now or 30 years from now, this is what you should do. And I'd be like, okay, whatever, Gramps, go away,
Oh, I totally get that. It's, as my full-time job is as a nutrition coach. And I would love to work with a lot more young people with families that have young kids and really help them implement better nutrition habits from a young age and not have to worry about getting sick at all. But most people that age don't really care at all because they're not yet feeling the brunt of...
you're bulletproof when you're 20, man. When I was a 20-year-old kid in college, I'd go work out during the week, and then I'd go partying on the weekends, and, Monday started again. There was no really effect to that. I always still felt pretty great, once the hangover wore off, but now, man, at 60, heck no, man. Not even want to even look at alcohol these days. This is crazy. You just don't, and like I said, you don't have the mileage on you yet, so you don't appreciate that. So this is when, I see people in their 20s and 30s saying, oh, you got to have carbs, you got blah, 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 and you're an idiot if you don't use them. I'm like, well, let's just see how you feel in 20, 30 years. When you have that biceps tendonitis that keeps bugging you, instead of having to sit there and inject all these damn meds in there, maybe your diet has an impact on there. And I'm utterly convinced that it does. I believe that for some people, certain foods, and often sugary foods, are what inflames their joints, their tendons, and they feel it. And it's just the way it is.
Yeah, you obviously are convinced yourself. I'm convinced there's enough, at least anecdotal evidence of... Well,
there's scientific, there's studies that look at that too. There was a nice study, University of Alabama, comparing low-fat to low-carb diets on knee osteoarthritis. Low-carb diets blew low-fat diets out of the water for relief. There's quite a bit of scientific literature that supports this, and there's mechanisms, high insulin level increases the secretion of inflammatory cytokines by the synovial sites. There's supportive literature out there that looks in that, and it's just, we see it anecdotally, and it may not affect everyone equally. I don't think it does, but for those where it does, it makes a difference. When you're 50 and your knees hurt, you're not going to feel like going and doing box jumps and hang cleans. This is not happening, right? But when you feel great, it's like, well, why not, man? Why not stay young? Why not stay fit, athletic, and explosive?
Yes, and you might be aware of research that I'm not. Now on the more mechanistic side of things, I have read through quite a bit of research that does explain why somebody might feel better. But there are, to my understanding, there is a lack of at least long-term RCTs or randomized controlled trials on at least carnivore specific. So I believe a handful of years ago, even pretty well known in our world, Stanford nutritionist Chris Gardner has said that it's unethical to study people on a carnivore diet.
Yeah.
So just curious, what would you say to that? Now, I think he was referring to, well, if we take people and we remove certain necessary nutrients and such that plants provide, then we're quote unquote knowingly harming people. So how would you respond to something like that?
Well, I mean, and I appreciate, Chris Gardner's opinion on that, but I mean, it flies in the face of reality. I mean, there are to this date hundreds of thousands of people that have been on these diets for various periods of time, for a few weeks to years and years and years. So the people are already doing it. So if it's if it's unethical, then just have the people that are already doing it and just see what's happening with them. The other thing, if there's any concerns, it's like they study vegan diets all the time, even though they know that things like B12 are deficient. So what do? They just provide a supplement. So if you're like worried about vitamin C, or just give all the participants a multivitamin. Okay, there you go. There's that concern mitigated. And I am absolutely convinced you could convince thousands of people that would be willing to be participants, because I know they are. I mean, I've tried to get these studies done over the years. It's just extremely, extremely hard to get them funded. And fortunately, there are some that are en route right now that are being funded. That hopefully will come to fruition in the next couple of years. I mean, as far as RCT type stuff, I mean, this is where they cost a lot of money. I mean, it's hard to do a good RCT under $1 million, and this stuff doesn't fall from the sky. There's not a lot of If I was a drug company, it's kind of funny when I see all these GLP-1 drugs, and there's already hundreds of studies on GLP drugs, even if not, maybe thousands of them, and some of the effects that they're getting are not too dissimilar to carnivore, in the fact that they have these outside of the weight loss and the diabetes indication. They're saying, oh, it looks like some of these people are noticing less addictive behavior. I see it all the time in carnivore. I see people that quit smoking, they quit drinking, that they lose that desire, but no one studied that, because again, we don't have Eli Lilly or Novo Nordisk or Pfizer or whoever the hell wants to, that has millions and millions and millions of dollars, tens of millions, if not hundreds of millions of dollars in research funding, that they can do this. And so we just try to, hopefully the government would be willing to pay for some of these, but even there, the appetite is pretty small. So it's tough to get them funded.
Yeah. So, I mean, given the number of people that are just doing it on their own now, carnivore diet, that is, to me, it seems almost unethical not to, for the NIH to provide funding for some of these studies. Just, I mean, people are going to be doing it anyways. Obviously, they are, and they're seeing a lot of success, especially on top of that. So, have you heard of any good reason why that funding has not yet been made available from basically public funding sources such as the NIH?
No, I don't. I know it's competitive to get NIH grants, and everybody in the world wants to have their funding studied for. And I'm not a clinical researcher, so I can't do it personally. I've over the years, I've found some people that have been sort of willing to fund some studies, and trying to connect them with the researchers, but it's hard to get enough money together with that. I mean, yeah, and you're right. I think it's unethical not to study this stuff, given that, I mean, clearly there are benefits, and and likely there are some associated risks, and so it would be nice to know the risk benefits outside of what we can look at anecdotally, because it's while it's data, it's a little bit harder, because there's survivorship bias, and all these different biases that go into that, and so. Yeah, it would be nice to have a couple of RCTs where things are looked at very, very critically and objectively, so we could confidently tell people, hey, now my company Rivero, we are collecting data on all of our patients. Now, not all of our patients are on a carnivore diet. We have some on keto, some on low carb, some on various just versions of eliminations. We have some that are on carnivore, and we're collecting their data, and we'll be publishing that as we accumulate enough to do so. But at the same time, yeah, it'd be nice if the NIH would just say, "Hey, look, we're going to do a couple carnivore diets." I mean, there's a whole bunch of low-hanging fruit ones that should be done. I mean, like particular things around like inflammatory bowel disease. This is Crohn's and ulcerative colitis. I mean, that seems to be, in my view, one of the best indications for it. I mean, these people that, if they, they're told by their gastroenterologist that, diet has nothing to do with their gastroenterology problem, which is insane in my view, and then they put them on these expensive, high side effect profile, immune suppressive drugs, and then half of them end up having some of their guts cut out because the drugs eventually fail, and there's no level of interest. And then even if you see people that literally, they've had this disease for 20 years. They've been on 10 different biologics. They have part of their intestine removed. They go carnivore and they become completely asymptomatic. Everything's gone. All their inflammatory markers are gone. They come off all the meds. They're like, my life is new again. And they go back to the doctor, and the doctor's like, oh, that's cute. That's cool. That's kind of cute. Keep going. They don't have any curiosity in it because, again, physicians are kind of trained to do what they're trained in, and they're not really trained in administering diets and administering lifestyle, and they don't have time for it. And they're not paid for that. So unfortunately, there's no real incentive to do these things.
Mm-hmm. So talk a little bit more about then, you mentioned Rivero. That's the clinic that mm-hmm. I think you've helped found. Is that correct?
Yeah, it's an online, we're licensed in all 50 states, and we see patients from all over the United States. We have physicians, we have a healthcare team. We work intensely with our patients, very, very closely, providing them all kinds of support. I meet with all the patients, I provide I provide a meeting that all the patients can come to at least twice a week, where I can talk personally with the patients. We have, we're monitoring labs, monitoring daily biomarkers, looking at patterns, making changes, getting people off meds, often very quickly, seeing all kinds of success: weight loss, diabetes reversal, inflammatory markers coming down, meds coming off, diseases going into remission, which is really cool. We just signed our first contract with a commercial enterprise, so we've been consumer focused, but now we're going to start working with businesses as well. And that is something that I'm super excited about because, it's not just people getting healthy, but it's also a cost thing. I mean, when you got somebody who's got some, autoimmune disease and they're spending $60, $70, $80, $100,000 a year on immunosuppressive drugs, and this is not an exaggeration. That's what it costs. And you put those diseases in remission. I mean, that's a huge health saving, not only just for the company, but for everyone in general, because everybody has to pay these super high premiums now to support this ridiculous healthcare cost. We're up to, I think I saw $6 trillion a year in spending on our healthcare in this country, which is just, it's probably 70% of that. If you get rid of some administrative waste and some of the just, reactionary medicine, we could probably cut that by probably 70% or more.
Mm-hmm. Yeah, definitely. I definitely agree with you on that one. And so in your work now then, is it correct to say that your primary tool is nutrition based? Yeah,
it is among the tools. Yeah, but I think the major lifestyle factors that we focus on are primarily nutrition, sleep. I'm a big proponent of activity and exercise, as you might imagine, stress, a little bit of circadian biology. I think those things are all relevant. And then, of course, managing the medications. And this is where the physician side of things comes in. It's sometimes unsafe for a patient just to quit medicine willy-nilly. Sometimes there's a taper that needs to be done, or changing medications or something like that. So, nutrition is a huge part of it. I think it is a critically foundational piece. I think if you don't get the nutrition right, everything else is going to be less effective, and sometimes ineffective, depending on, how bad it is.
Mm-hmm. Yeah. So in my own work as a nutrition coach, a good portion of my clients are in the kind of the 50 to 90 years old age bracket. And so a vast majority of them are on, at minimum, 1 or 2 medications, and most of them quite a few more than that. Yep. So curious, in your practice, how roughly just rough estimation on percentage of patients that you see that are able to reduce or eliminate medications, and how many patients do you see that you may actually add some sort of medication?
Yeah, I would say the majority of patients will end up coming off multiple medications. That's been my experience. It's not unusual for people to come off 3, 4, 5 medications after, a couple months with us. It's pretty unusual that we add a medication. It's not unheard of, but it happens very infrequently. Most of our doctors and providers are deprescribing. That's probably 98% of what they do. Adding a new medication. Sometimes they might change something, but generally it's because what happens is, our whole rationale is doing lifestyle things which should direct people to come off medication, which is, that's what medicine should be doing all along. I mean, medication should be reserved for extreme necessity. It should be the kind of a last resort in many cases. I mean, there's obviously exceptions to that. I mean, obviously there's times when medication should be the first line, but for most of this chronic health stuff, I mean, we should be optimizing the lifestyle, maximizing the lifestyle as much as possible. And then for those ones that are still recalcitrant, that's when we, consider medications, instead of the opposite where, people walk through the door and lifestyle is given lip service and the doctors complain because it doesn't work because they don't really facilitate it. I mean, it's like, the whole healthcare system is like, well, we tried lifestyle and the studies show it doesn't work. Well, what did you do? Well, we told them to eat less and move more and eat a low-fat diet, and they couldn't stay with it, so let's give them all drugs now. And I mean, that's kind of a half effort. It's like, the analogy for that would be if I said, hey, hey, Alex, let's say pretend you're older. And I said, hey, Alex, your knee's pretty bad. It's pretty worn out. We need to do a knee replacement. And you agree. And I said, okay, Alex, now go figure out how you do it. And left it to you to do it, right? The success rate would be pretty low, guys in the garage cutting their own knee open. So when we as physicians tell people, hey, you need to lose weight and exercise, and we don't give them any guidance, support, feedback, motivation, accountability, they just fail. And then we say, well, it doesn't work. And then we start giving them pills. And that's really what the thing is. And when you provide all those things that I said, the success rates are much higher. And I think that's the thing we need, and we need more research on that. We need to figure out what interventions really work, how to time them, how to implement them. But again, as I said, there's no big drug company making hundreds of billions of dollars on this, so the research is hard to get done.
Yeah, definitely. And that's even with the research then. So the research that is out there, do you ever personally go through and read an entire research report?
Oh, yeah. I mean, I've read hundreds of research papers. I mean, it depends. I mean, it depends if I'm interested in it or if it's relevant or whatever. If it's, like I said, I don't spend all day reading research papers. I mean, there's a lot of things I'm involved in, but I mean, yeah, I've read plenty of research studies over the years for sure.
Okay. So the reason that I'm asking actually just this morning, and I have this experience quite often because I'm personally reading quite a bit of research. Just this morning, he's a pretty popular nutritionist he's got a YouTube channel. I think he has over 300,000 subscribers. I believe he is a PhD. And on X this morning, he had posted a paper, and in his own words, his summary was that when calories are equated, macronutrients and varying the amount of carbohydrates in a diet has no impact on the success of weight loss.
Okay.
And then in that paper, I opened it up and read through because I already, based on what he had written, I had a handful of questions about this actual paper. And so it turned out to be a meta-analysis. And in the criteria for the meta-analysis, what they were calling as low carb was anything that was below 45% of energy in that food as low carb. So it could have 900 calories out of a 2,000 calorie budget coming from carbohydrates. And to me, I don't know anybody in the low carb world that would call it remotely close to low carb. So, and we had a little back and forth on this, and he kept defending his own position on, well, low carb, there's not really any official term, there's no official definition of what low carb is. And so, yeah, this below 45% of energy coming from carbs, that's low carb. And so it's frustrating to me one, if that is what he is considering solid research, then to me it's pretty hard to trust whatever he has to say. The other option would be, he didn't actually read this study. He saw the headline and posted it. And for some reason, he's defending that he didn't actually read what this study had to say. So those are the two options that I come up with. But in your own analysis of research, are there any easy things that you first look to see if this research is remotely reasonable and can actually tell you something?
Well, I mean, first of all, you kind of summarize what the category of the research is. So if it's an observational study, it's hard to infer causality on that. So I mean, there's a lot, and that's probably, 80% more of nutrition research is all this so-called epidemiologic stuff, where you just kind of like, okay, that's nice. You can make an hypothesis, and they go both ways. I mean, you see studies that are meat is good, meat is bad, eggs are good, eggs are bad. I mean, it's on and on and on, and then so you start looking at, maybe there's some RCTs, and depending on who they're doing the RCT on, is it the population of interest? Is it general pop? Is it people that are on a low carb diet? Is it people that are metabolically healthy? Is it people that are metabolically compromised? And so there's all kinds of variables you have to see if it's applicable to the patient in question. I mean, there's a lot of, like I said, I as a physician deal with individuals, not populations. And so for me, it's like, what is going to be appropriate for this particular individual? I don't disagree that, when you match protein and calories, weight loss efforts are not too dissimilar. I mean, you could argue, obviously you can say, just protein alone shows you that the macronutrient composition matters. There's a thermic effect. There's an increase in need in many cases on high protein diets or non-exercise activity thermogenesis. There's some studies that suggest low carb is better than low fat when it comes to, metabolism. I mean, that's controversial. I mean, it's, that kind of gets into the minutiae there. But at the end of the day, this is, you think about it, we've been told for, 30, 40 years from the mainstream nutrition establishment, it's all about, calories in, calories out. And yet we have this huge obesity epidemic, and all the people that have been telling that are now shifting over to, well, it's genetic, it's a disease, here, take these pills. Because the calories and calorie counting didn't work, right? Obviously, it's not working for you because there's satiety and hormonal influences here that are at play. And we know that macronutrient composition or food quality composition can impact those satiety signals. And so now we have drugs that influence those, and people are losing weight, right? So it's like, well, wait a minute, what happened? Did it make the calories not count as much anymore? What's going on here? No, there's satiety. As Gary Taubes and others said, well, it's, to say stop eating as many calories and burn more is not very useful to the average person. It's like, well, yeah, okay, yeah, make more money than you spend, you can become rich, right? It's easier said than done. So, so I don't really, even in my book, The Carnivore Diet, which I wrote, now 6, 7, 8, almost 7 years ago, 8 years ago, I said, I don't really like talking about obesity because it's so contentious, and I'm more interested in the unique disease mitigation outcomes that I see with things like a carnivore diet. I think they are unique, and I think that they outperform other diets. And it isn't always just down to weight loss, because I get people that are emaciated, like these rheumatoid arthritics or these anorexics that are, they need to gain 20 pounds. And it's not about losing calories, so those people, they get healthier, or we get people that will, in absence of weight loss, see their symptoms go into remission. This is one of the things that first got me into this space. I was taking care of total joint patients. I had patients on my surgery schedule for knee replacements, and we wanted to get them to lose weight prior to surgery. So I would put many of them on a ketogenic diet, and I would check in on them, 2 weeks after I first talked to them about the diet, and a lot of them would come back to me, and they had lost maybe 2 or 3 pounds at most, but their knee pain was gone. And so it wasn't like weight loss. they were still 100 pounds overweight, but their knee stopped hurting. So I was like, what's going on here? This is interesting, right? And so that is, but your question about research, it's hard to do. It's really hard to do good nutrition research on humans. Because one, by definition, they're going to be short-lived studies for the most part. You can't really, a high quality, like when you do animal studies, you can do it as long as you want on the animals. You can control every variable. You know exactly how much exercise they're getting, where they're sleeping, when they're sleeping, what their environment is, how much they're eating. You're measuring all that stuff, and then you kill them all at the end, and cut them open, and see what happened. You can't do that stuff on humans, or at least not ethically. And so, human studies are it's just not really good science in general. And I think most people that are in that space will admit that. And what they'll say is, well, we have to infer conclusions based on the best we can do, and I'm like, well, you got shitty data. It's just not, you can just about ignore a lot of that stuff. Even though you can try to do the best you can, but it's just like, garbage in, garbage out. And so it's hard to take a lot of that too seriously. Now, I certainly will put up studies that support, the position. I've put up epidemiologic studies, even though I'm very critical of that, just to show that these things are all over the place. You've got people out there saying that, oh, red meat is going to give you whatever, colon cancer. And the study comes out the other day that shows vegans had the highest rate of colorectal cancer. And why is that? I was like, it's just like, why is that? Why doesn't everything line up, consistently on one side? Why do we have these frequent outliers and these contradictions? It's because the data is just so sloppy. It's really hard to get good data.
Mm-hmm. And I think that's, a lot of things that you just mentioned that are worthwhile to point out. But ultimately, one thing that I've really appreciated about listening and learning from you over the past years is, obviously you have a fairly, what most people would consider a very restrictive diet, and you're only eating meat and animal products, which to most people seems extreme. But ultimately, despite your own personal decisions, your own preferences, there is a lot that we don't know, and you're very open and willing to admit that, and especially on the longevity front of what happens 20, 30, 50 years down the line of doing this. We don't have the data to know that. Now, anecdotally, and what you see all the time in your clinic is, and for yourself, is people that do these diets, many of them get way better. And so, at least at very minimum in the short to mid-term, their quality of life is much better. And so there is, I think, even if it's not necessarily an RCT, to me, that's enough information to say, you know what, some people probably should try this out to see what happens. But a question that stems from that, though, is, okay, let's say we do end up being able to fund a high-quality, long-term study that looks at people that have been carnivore for multiple decades. Is there, or what data might come from that? Is there any data that there are certain outcomes or lab work that would make you question, despite all the success that people have in the near term, despite the fact that they're getting off medications and their joints aren't hurting at all, and they're either losing weight if they need to lose weight, or sometimes they're gaining weight when their BMI is way too low. So are there any of these longer term outcomes, if we did find something, would make you pause and say, maybe it's not worth it?
Well, again, I think these things are all come down to the individual. Now, let's just say in fantasy world, somebody would be willing to spend, $500 million to do a 40-year RCT with people on, metabolic wards, doing a carnivore diet and comparing it to other diets. And we found out that the carnivores lived 10 years shorter than everybody else. They had higher rates of heart disease. They had more cancer. And these things are all speculated to be true right now on that. And it showed that, that's definitely the case. And it was a good, well-designed study. I would say, these are the known risk factors. Is that outcome worth it to you to not have blood coming out of your butt every day and going to the bathroom 20 times a day with your ulcerative colitis? Or is it worth not having crippling suicidal depression? Is that worth it to you? And then you just share it with the patients and let them make the decision like anything else. It's kind of like, years ago they polled Olympic athletes and said, if you could take a drug that would shorten your life by 10 years, but you would automatically win the gold medal, like 80% of them said, hell yes, I'd do that. So, you have to give it to the individual and just inform them the best you can and let them make the decision. And I tell people that all the time because, one of the bigger concerns is some people, when they go low carb, will see their cholesterol go up. And cholesterol is considered a causal agent when it comes to atherosclerotic heart disease. And I know there's a lot of pushback and feedback around that, and I'm not going to go into all the nuance around that, but I tell the patients, hey, look, if for some reason your risk for heart disease is increased by 20, 30, 40%, is this diet still worth it to you, given what's going on? And many of them will say, absolutely, because my life was a living hell before this. I couldn't even function in society. I was in pain all the time. And my quality of life is so much better that I'm willing to accept that theoretical risk or maybe even real risk. And so, again, you just have to, like I said, with anything else, there's no one that, is out there telling people, there's people out there eating Twinkies and Ho-Hos and chocolate chip cookies and cake and ice cream for half their diet. And, there's no one like giving them we know it's bad for you probably. There's people out there who say as long as that stuff was done in a caloric deficit, then no big deal, right? It's no problem. So I'm not really concerned about that. It'd be cool if we did some studies. I would like to see, from my perspective, I'd like to see studies, RCTs done on certain conditions. Let's say it's Crohn's disease, let's say it's multiple sclerosis, and see what percentage of people respond to a diet. What people respond. Is it 10%? Is it 50%? Is it 80%? I don't know. I see the success stories. My gut intuition is it's probably better than 50%. And that's powerful information if we can know that. So we could say, hey, look, if you've got, like this 15-year-old kid gets diagnosed with Crohn's disease, and you can say, hey, guess what? If you go on a diet for a year, you might put this in remission. You can avoid, having a colectomy. You can avoid being on a lifetime of immunosuppressive drugs. We should know that information, and say, hey, look, because some people would make that decision. I know I would, So it's one of those things where it's just a shame that we're so. And everybody accepts it. The drugs are going to save us all. We're all going to, we're going to have magic drugs in the future, and we're all going to have, AI that's going to solve all the problems. And I'm not convinced. I'm convinced that it'll help people make a lot of money, and a lot more people will be on drugs. Whether it ultimately is a good thing or not, it still remains to be seen.
The conversation when you go to the doctor's office, both my experience, family and friends' experience, and clients' experiences, and even when I'm reading studies, it's very, very often the only endpoint is death. And that doesn't bring in at all quality of life whatsoever. Now that's both on the dietary side of things, the nutrition side of things, the physical fitness side of things, and also on the medication side of things. Like, okay, we'll give you a medication to make it so that your joints don't hurt anymore. We'll give you a medication to lower your LDL cholesterol. But what are the side effects coming from that? One, I'm not convinced that the benefits that may be seen on especially statins are coming really primarily from the lowering of LDL. My read on all the data that I've read is likely more of an anti-inflammatory effect, but that's a different conversation. But yeah, just the fact that there aren't these conversations in the doctor's office when these decisions are being made that are focusing on, here are the trade-offs of when you take a medication or when you focus on improving your nutrition. These are the benefits that you're going to get. These are the possible downsides that we may or may not know of. So just that fact alone, I think even that we need a shifting of that conversation. So in your experience then with working with patients and such, and the ones that have tried a carnivore diet, have you noticed any patterns on their specific conditions? I'm guessing joint pain might be one of them, but specific conditions that seem to benefit the most from a carnivore diet pattern, or any that just don't seem to respond at all and there's no improvement or rarely any improvement from?
Well, I think it's patient specific. I think most conditions that you can think of, chronic medical conditions, I have seen someone get significant benefit from. It's not to say that all patients will get that, but there's people that have horrible looking arthritis, horrible x-rays, I've been told they need a knee replacement, and they end up with no knee pain. And there's other people where they have knee pain, they go carnivore and they still have knee pain, and it just doesn't go away. So it's kind of one of those things where, the more common things go away commonly. So the most common things I see are obesity, issues with mental health, arthritic pain, joint pain. We also see a lot of gut issues. These are the more common things that people go to the doctor for anyway. So the common things are commonly made better. There's been a whole bunch of bizarre things like Tourette's syndrome and Ehlers-Danlos syndrome and myasthenia gravis and all these crazy things. You're like, why the hell would diet impact that? But it does seem to do that. But there's no all I can say is I would say that, for most people, doing it for about 3 months seems to be the the time that people may need to respond. I mean, there's some people who respond within days, but many people, it takes them 3 months to see a response. And I tell people, hey, if you haven't gotten any kind of improvement in 3 months, go find something else. I mean, I'm not dogmatic about this. I just try to tell people, find something that works for you, and this may be the solution for it. It may not be, but I mean, it's worth trying for a little while. And then if it does provide significant benefit, stick with it long enough to, maybe put something in full remission, and then add all these other things in there, which I think are important too. I think, as we talked about, the sleep and the exercise and so on and so forth. And then hopefully you can get into a position where you're no longer dealing with illness. And then many of those people are able to then broaden their dietary horizon a little bit. Maybe they incorporate a few whole food carbohydrate sources in there, and I have no problem with that. I think that's great if you can do it. I've done it. I've tried over the years to bring it in, and for me, it's just a net negative. It's not like horrible. It's just like, yeah, I feel a little better, and I don't mind eating steak every day. I mean, it's not like I'm being tortured or anything like that. I mean, it's pretty damn good food, to be honest.
Mm-hmm. A couple things just that pop out to me. What you just said there, and listening to today and over the years, is you seem very responsive to the individual, in that you're not dogmatic about being carnivore. You're not dogmatic about any specific thing. It's find what's going to work for the patient. Find what's going to work for the individual. And that 3 months, if something isn't working after 3 months, then whatever you're specifically doing, maybe it's time to look elsewhere. But I think for anybody really, when they're going to see their doctor, that is something that they should be looking for, is find a doctor that's actually going to listen to you and not just preach whatever their default is. So I really appreciate that about you. Before we finish up, I have a couple questions more. First, as an orthopedic surgeon, is it possible to regrow cartilage?
Yeah, interesting question. In fact, I just did a lecture on that a couple weeks ago in Las Vegas. To a degree, it seems to be that it is possible. Interestingly, there was a recent scientific paper that was put out, and it was in the headline. The news headline was Ozempic regrows cartilage. And again, this is an animal study, so you have to take that with a grain of salt. But they saw some similar findings, in human beings. Is that when these rats were given, I think they were arthritic model rats, when they were given Ozempic, they started to see cartilage regrowth. And the interesting thing was, it wasn't related to weight loss. What it was apparently related to, according to the researchers, was a shift in metabolic state, and that the chondrocytes, which are the cartilage cells, started to adopt, instead of glycolysis, a glycolytic pattern, they adopted a more oxidative phosphorylative pattern. So oxidative phosphorylation is associated with, as we know, ketogenic and low-carb diets, and so, and by extension, carnivore diets. And so I think to some degree, the cartilage is, it's largely avascular tissue, so there's no blood supply to the cartilage. There's no articular cartilage. There's no blood vessels in there. All the fluid all the nutrition is coming largely from a little bit from the subendothelial or from the subchondral layer, but most of it's coming from synovial fluid. And so that synovial fluid, some of that has to do with usage. I think cartilage responds just like our muscles and tendons do under stress, and so you have to provide appropriate mechanical signals as well as nutritional signals. And so the answer is, to some degree, yes. I don't think somebody's with a completely bald, bone-on-bone, no cartilage knee is going to magically grow a 20-year-old knee. I don't think that's going to happen anytime soon. Now, maybe they'll come up with drugs that do that. I don't know. But yes, I think there is some amount of that. And I've seen, I'm kind of skeptical as an orthopedic surgeon, because I'd like to see the MRIs. I'd like to see the actual arthroscopy photos and stuff like that. And I haven't seen much to support that, but there's some hints that might be occurring.
Interesting. Okay. I lied. I have two more questions. First, on the last two is, and I think you have personally in the past stated something that seems to be the case for a number of people doing long-term, very low-carb diets, is they end up seeing their fasted blood sugar and or A1C creep up over time to the point where it's borderline pre-diabetic. So let's say in that case where their fasted blood sugar is higher than I personally as a nutritionist would like to see my clients, but their fasted insulin is super low. In that situation, is that something that you would be concerned about? And why might that be the case? Why might that be a somewhat regular occurrence for people that are on a super low carb diet?
Well, again, I'm not sure how frequently it occurs. I know it does occur occasionally. I think there's a couple things that might potentially drive that phenomenon. One is, so a typical fasting morning AM blood glucose, which you might take, 7 o'clock when you wake up in the morning, and it's, 111 or something like that, and you like to see it under 100. Some of that might just be the fact that you're not actually fasting yet. That is to say, if you eat a big steak at night, it may be spending 12, 14 hours still in your small intestine. It might take 3-4 hours in the stomach, and then it's going to slowly kind of work its way through the small intestine. So you may not actually be fasted at that time. So that's one particular consideration. People have talked about, maybe red cells are living longer and it might artificially elevate the A1C. That may or may not be going on for some folks. I think the other thing that's kind of interesting is if we go back into the metabolism literature from the 1920s, which is kind of interesting. They looked at that time, Eskimos, because they still call them Eskimos, even though it's considered politically incorrect right now to say Eskimos. But I think it was a study from 1927 or something. It was metabolism of Eskimos or something like that. And what they did is they looked at these Eskimos and they checked their blood glucose. And despite there being no evidence of any diabetic disease in that population at all, like no eye issues, kidney issues, nothing that would give the sense that there was any diabetes in that population, they tended to run a fasting blood glucose often in the 120s, And so, and their diet was largely carnivorous, right? I mean, they would pretty much just eat, whatever marine mammals and fish and whatever they could get a hold of up there in the frozen north. And the other thing is that if you look at the physiology of other carnivorous animals like cats and even like dolphins, they tend to often run slightly higher blood glucose. And some people just say it's just a normal adaptation to carnivorous physiology. And so, those are all potential thoughts on why this may be occurring. Is this actually leading to pathophysiology or pathology? I don't know. I mean, I think it depends on the individual. I mean, obviously, why are we concerned about high blood glucose? Because glycation damage, and maybe we end up with nephropathy, retinopathy, neuropathy, whatever, cardiovascular disease. And so in those situations, you want to also monitor those things. Now, I mean, one thing was, hey, just fast for 18 hours when you check your blood glucose. Maybe that'll bring it down. Now it's 92 instead of 110. Maybe it's, some people, sometimes higher protein can sometimes stimulate that for some people, particularly if they already have underlying insulin resistance. If they've got a really low insulin and a high, 110 is not super high, but if you couple that with a fasting insulin of 2, their HOMA-IR score is still going to be extremely low. I mean, you're still going to have a very insulin sensitive looking picture based on those metrics. So, I've seen, one thing you can do in that situation is go very, very ketogenic. You can just eat 85% fat and limit your protein, and your blood glucose will reliably fall. The problem with that I see is a lot of people, they lose muscle mass when they do that, and so they end up becoming more fat. And I'm like, is that a better solution? Would you rather have a blood glucose that runs, 107 compared to 80 and be lean and muscular, or would you rather have a low blood glucose and be fatter? And I'm not sure what's the better solution on that. I mean, my bias is I'd rather have a slightly higher blood glucose and have a lot more muscle, because I think it's more functional. But, it's one of those things where, and the other, obviously the people that are completely against carnivore would say, well, we know that, for instance, branch chain amino acidemia is associated with higher rates of diabetes, and red meat and some epidemiologic studies will be associated with diabetes, and, lipotoxicity is associated with beta cell failure and so on and so forth. So I don't think it's clear cut. I mean, it could be that the person getting sick, or it could be that it's just a normal physiologic response. And, it would be nice to be able to, again, study these types of things, which, again, as you pointed out, hundreds of thousands of people doing these diets. Maybe we should do some studies on this stuff. I would love to see that. But yeah, that's kind of some thoughts on that, observations on that.
Yeah, absolutely. I mean, ultimately, I agree. A lot of it does come down to we need more research on people that are caring about their metabolic health, because ultimately both of those questions that I just had, something that I struggle with all the time reading scientific literature is, well, we're studying the population that we have. And today, especially in the Western world, it is a relatively unhealthy population. So even then when we come out with, okay, what are optimal ranges for metabolic markers, do we even have the correct ranges for the healthy population? And even then, is a healthy range for an omnivore or a healthy range for a vegetarian similar to a healthy range, as in healthy based on immediate and long-term outcomes, a healthy range for somebody in carnivore? And I think that's, like you're saying, I mean, I personally think we don't know, and it sounds like you may be in the same boat. Ultimately, for me, I think if right now where I stand is if fasted insulin is low, it's much less of a concern, if any at all, despite if there is a slightly higher fasted blood sugar level. But yeah, it's a question that I ask myself quite
well,
often.
I mean, again, I think in that situation, we just have to explore what else might be going on and try to answer questions. It's the same thing with high cholesterol. I mean, I never tell a patient that comes to me and says, hey, my cholesterol's really high. I never tell them to ignore it. I mean, there are people in the keto, carnivore, low carb space say, oh, cholesterol has nothing to do with heart disease. You can completely ignore it. I'm not that guy. I'm the guy that says, hey, look, let's get some more information, weigh the risks, benefits, see if this diet's benefiting you. Do you need to change your diet? Do you need to modify it? Do you need to add medications? Do you need to just wait and get more information, maybe get some more imaging? Those are the types of things. I think that the high blood glucose is a similar type of thing. Like, let's see if anything's going on there and how can we adjust these.
I'm right along the lines with where you are. I think of a high LDL is not necessarily an unhealthy thing, but just because you have high LDL doesn't mean you're in a good place, and there could be concerns relating to a high LDL depending on what your health context is. So it's not just we don't care about cholesterol whatsoever. But last question before I let you go, I'm curious, is there anybody or any condition that somebody would be in that they come to you and right off the bat that you would specifically recommend not doing a carnivore diet?
Not really. I mean, it depends. Most people that come to me want to do that. I mean, that's the reason they consult me, because I'm somewhat of an expert on this. But I mean, I guess there's people that just aren't going to do it. I mean, it's just like, if somebody says I'm a vegan, I'm not going to tell them to do a carnivore diet. Or if somebody has, maybe they have an allergy to red meat. I mean, we know there's this tick allergy that some people get where, it's more challenging. I'm more often likely to suggest a plethora of options and say, which one sounds the most appealing to you? I mean, some people would say, hey, let's do a ketogenic diet for a while. Let's do a low carb diet for a while. Let's, eliminate this or that. Let's just eliminate, bread and sugar for a while. I mean, it's not necessarily the first thing I suggest to people unless they specifically want to do that. Then I talk to them about how they might go about that. But yeah, I mean, I guess there's a few like inborn errors of metabolism where, you could have certain problems with protein that you'd have to be a little bit cautious around. But I mean, for the most part, I don't really know that there's a lot of absolute contraindications to doing a carnivorous diet. I just don't know that there are.
Mm-hmm. And I suppose we need more research to know if there are. It's the theme of the day. All right, well, perfect. So before I let you go, let people know where they can find you, learn more about you, learn more about Rivero if they'd like, your socials, that type of thing.
Yeah, Rivero.com. If you are a patient in the United States that has metabolic disease, obesity, diabetes, hypertension, autoimmune disease, inflammatory disease, we'd love to help you. We got a team standing by, doctors in all 50 states that can help you out with that. I personally on a Zoom call twice a week with all the patients that want to show up. So you can ask me questions directly if you want. I also on the side will do a little bit of individual consulting. So it's if you any of my social media, you can book a one-on-one consultation with me, and I can talk to you guys for whatever you want to talk about. Social media wise, on X, I'm at SBakerMD. I'm on Instagram, Shawn Baker 1967, and the rest of my socials, YouTube, Facebook, I think TikTok, are all, and Rumble, I think, are not Rumble. What's the other one? Spotify, are all Shawn Baker MD, I believe. So anyway, any of those you can see me, and I'm pretty much posting stuff most days.
All right, perfect. And if you ever want inspiration on getting out there working out, whether it's in the gym or outside, you should follow Shawn Baker. He's got some pretty impressive videos. So perfect. Well, thanks so much for giving me an hour of your time. I have so many more questions that I'd love to ask, but I will be respectful of everything else you've got to do. So yeah, thanks so much for joining.
All right, man. Well, I got to go do some power cleans. So thank you, and maybe we'll do another round too if you got a bunch of questions left. Okay.
Sounds great. Thanks so much.
All right, man. Thanks, Alex. Appreciate it.
Thanks for tuning in. We're here to help you put what you've learned into action. Learn more about our coaching program at highenergylife.com. That's HIenergylife.com. Until next time, embrace nuance, ask questions, and always reserve the right to change your mind.